I think, well, I'm Kathy Kelly, I'm a resident. Have to talk a little louder? Okay, nothing wrong with my hearing. Be careful what you say. I'm a resident, and I've been on the wellness committee. This will be my 6th year. But there is a new director, or a chairperson, Debbie Pearson, but Debbie's not here today. She's at a conference. So, but I have the joy of introducing and having 3 people who you've probably seen many, many times. And I'd like to, we start with my introduction, will be Kathy. Kathy Cody's going to kick this one off. And tell you a little bit about Kathy, just a little. I'll leave it up to her, unless she told me I could say anything I wanted. Born and raised in Boulder, Colorado. And she has her degree, a degree in bachelor's in biology from San Jose State. She worked as a medical technologist. That's why she does so well, taking bloods, and in toxicology and special chemistry. She really wanted to do more than be in a lab. She wanted to work with patients. And so she pursued her nursing career. She entered and received her doctorate in nursing at the University of Colorado in Health Sciences. And then she obtained her RN. And so she's been, she said she's been to every school there is. She's a career student in nursing. Upon graduation in 2001, she worked in Denver in skilled and long-term care facilities. She moved to Austin in 2004, worked in Temple and in Austin. And then, lucky enough for us, Westminster in 2009 started the wellness clinic here. And I thought it was around much longer, but I knew Kathy was invited to come down here or up here, wherever you were at the time, and to cover the assisted living and the arbor when it was all in one building. And so the new buildings were built and more people moved into Westminster. And they added the other NPs, nurse practitioners, and Kathy, Mindy, and Ann will describe what all the letters are behind their names because we've been having a discussion what the multiple alphabet is up here on the screen. So Kathy, would you? Oh, Ann's going to go first. Well, that was Kathy's introduction, so thanks.
Do you want to do Ann's? Do you want to do Ann's? You want to do Ann's really quick? We can skip it.
Well, it's very, very funny, and anybody, Ann's done more in traveling as a nomad,
That's
as
right.
a wanderer.
I've hardly been a nurse at all.
Yeah. So if you ever want to know, next time you're in the clinic, and you just say, hey, tell me more about yourself. You may be there longer than you thought. It is very funny, very career-oriented. And Lipscomb.
Thank you very much. So I have to get close. Can you guys hear me? Yes. Somebody in the back says yes. Okay, yeah, I know I'm amplified now. Okay, so this is a presentation about what's the difference. Colds, allergies, influenza, RSV, which is respiratory syncytial virus, and COVID-19. So this is something we do every year, and some of the presentation gets tweaked a little bit depending on what the vaccines are and what the different treatments are and the recommendations. So pay attention because it is a little different. So colds, we're all very familiar with this. It is something that's very common common. So the common cold symptoms are, anybody could do this presentation. Stuffy nose, a runny nose, a cough, malaise, which is the French word for I feel bad, sneezing, sore throat. Maybe you might have a little bit of a fever, but it's not generally high. And not usually any gastrointestinal problem. There's no nausea or vomiting involved in a cold. Thank goodness. So the timing of a cold. So how, when, how long? So usually the incubation period from the time you get exposed to the time that you start having symptoms is about 24 to 72 hours. So if you had lunch with your friend and they had a cold, you can look forward to 1 to 3 days before you get a cold. So the onset is 1 to 2 days. The contagion, how long are you contagious once you have the virus? It's before you get sick, -1. So your friend that you had lunch with could be well, but they've got a cold and you get the cold. So you're contagious from day -1 to about day 7. And the duration, how long are you going to be sick? Usually a week and a half. Maybe longer if you've got any breathing problems or you're immune compromised at all. Could be longer than that. Usually the cough is the last thing to clear up. So what do we do for a cold? Even though it's the older one of all the different viruses and symptoms we're going to talk about, we still don't really have any cure. So there's symptomatic treatment. Talk about things for fever and malaise and achiness, Tylenol, all the things that you have up on the screen. The stuffy nose, we really like to recommend a nasal saline rinse. That's really helpful. For the cough, just the old-fashioned lots of warm fluids, cough drops, some over-the-counter cough medicines. If you're using a medicine, if you go to the drugstore and you buy a cough syrup or a cough tablet that's got more than just the name of the cough syrup. If it's a combination, read the label, check it out, try to be aware of what medicines are in that combination product. Because sometimes it's not clear when you first buy it, and it can interact with either some of your conditions or some of your other medications. So the best prevention for a cold is prevention. The best treatment, prevention, the wash hands. So cover up your sneezes and your coughs. If you're using a Kleenex or a handkerchief, wash your hands when you're through with that. Throw it away. So soap and water is really the best sanitizer. Hand sanitizer is good, and it's very convenient. You can carry it around with you. So pay attention and try not to touch your face. Rub your nose, rub your eyes. So the next thing that might show up that we always wonder, what is it? Is allergies. I know a lot of times people thought that when they actually had COVID, they kept saying, it's just allergies. It's just allergies. So a lot of times it's really, really hard to tell. So we all know the symptoms of allergies. And some of these are pretty specific. They're a little more indicative of just an allergy. Sneezing. You can sneeze if you have a cough or other things, but you're sneezing a lot, that's a sign it might be allergies. Itchy, watery, red, swollen eyes, maybe a scratchy throat, stuffy, runny nose. Some people get a little dizzy, feel a little off balance, because it affects your inner ears. You can be really tired. You can get a lot of just fatigue with allergies. And a cough, usually a dry cough. This is a slide that shows in this area, over the period of a year, looking at the different months, what is most common that might cause allergies. So you can see that first big yellow hump on the far left is mountain cedar. Yeah, so that takes us from the beginning of December to the middle of February, give or take a month or two. Yeah. So a lot of times people know it's allergies because they have a special time of year that they get sick in the same way. There's allergy season. You can always check the newspapers, either in print or online, to look at what's blooming, what's in the air right now, how much of it is in the air. Is it mold? Is it cedar? Is it grass pollen? And that can give you an idea about what you might be reacting to. So there's not a contagious period. This is not something you're going to give somebody else. It's something that you are going to get because you're breathing. So there's no incubation period. When you get it, you get it. So prevention and treatment of allergies. This is a little bit more detailed than the cold and the other stuff. So there are a lot of over-the-counter preparations for allergies. Generally, they're called antihistamines. We know them by various names: Claritin, loratadine, Allegra, Benadryl, diphenhydramine. So you can just go to the drugstore, look in the aisle that says allergy. There are nose sprays that people that have really bad allergies can use. Astelin, Astapro, those are things that works particularly for allergic nose symptoms. And drops that you can get over the counter, particularly for allergic eye symptoms. Or there's also a prescription for that as well. There are steroids. I know when I used to work with a broader range of ages, people would come in, and then particularly people from Mexico would come in and say, I want an allergy shot. And what they meant was a dose of steroids injected. And we used to do that more. It's very effective, but steroids are pretty strong medicines. They work really well, but they're not something that you want to be using very often. So we don't do that anymore. But allergy shots are still available from allergists, where you go in and they test you to find out what are you allergic to, and then they make a potion for you and get you a series of injections to get your body used to whatever it is you're allergic to, so you're not reacting so strong. So, influenza, the next terrible virus, respiratory virus. So, I'm reading, it changed the A component to A-Kansas-14 2017 H3N3 light virus. So there's a lot of information. These injections, the shots, and the virus itself mutates. The virus mutates rapidly. That's why we need a shot every year. So the symptoms of influenza, one way that clues the nurse practitioners into this might be the flu is that people call and say, I'm exhausted. I can barely lift up my hand. I'm in bed. The other symptoms are really similar to colds and even sometimes allergies. So muscle aches, cough, stuffy runny nose, not really so much sneezing. We think of sneezing with colds and allergies, not so much with the flu, but it could happen. Fever, chills maybe, headache, and it can have gastrointestinal symptoms with it. So you can get nauseous or vomit or have diarrhea with the flu. That's another sign. It's more than just the cold, it's more than just allergies. So here we go again. How long do you have to be careful? So the incubation, from the time you get it to the time that you start feeling sick, is 1 to 4 days. It's a pretty big range. You might have totally forgotten what you did 4 days ago, who you were with. The onset, we generally say it's rapid. You go to bed and you're fine, you wake up and you're really sick. You're contagious once you get the virus before you get sick. Again, like a cold, 1 day before you get sick to probably around 7 days after your first symptom. And the duration, again, is 7 to 10 days. It will be the longest 7 to 10 days of your life. The cough and the fatigue might last for a lot longer. And that tends to be the case once we reach 65 and above. Things just take longer to get better. So prevention and treatment. We're coming up on our flu vaccine clinics. So everybody sign up. There's a folder outside the clinic in the waiting room that you can sign up for your flu vaccine. If you get your flu vaccine elsewhere, stop by the clinic and let us know, and we'll put it in your record. So a vaccine reduces the risk of needing to go to the doctor or the clinic by up to 60%. So it's not 100% guarantee you won't get the flu, but it won't be as bad. People who are vaccinated yearly have better protection, even the years after. So if you're one of us people that are good about getting your flu vaccine, you're less likely to get the flu every year. The bad news is that the protection against the flu wanes after about 3 months. So we try to give it right before the flu season, so you're covered during the worst part of the flu season. You've heard this before. Wash your hands. There are treatments for the flu now. There are antiviral pills that are specific to influenza. Tamiflu or Zofluva. They are can be used for prevention. If you've been exposed, you were in a car with somebody, you found out that they have developed the flu, and you want to prevent yourself from getting the flu, you can get one of these medicines. Or it can treat you if you're already sick. You have to start the medication within 72 hours, 3 days of getting sick. So that's good to keep in mind. If you think you might be getting the flu, don't wait a couple of days if you think you might want medication. So Fluzza. It makes me think of the word floozy. So that's the newest antiviral flu medication So you can treat cases that we already know you have the flu, or you can prevent it after exposure. So the dose of Xofluza is 2 40-milligram tablets one time, one dose. And Tamiflu is 1 tablet twice a day for 5 days. You have to take within 48 hours of exposure. So the sooner the better. The price without insurance is pretty hefty, but I think most folks here have pretty good insurance. And what they'll pay depends on the insurance. But this says it's covered by most Medicare drug plans, but they're all a little different. So symptom management of flu, it's going to look very familiar to the rest of it. So the malaise, the feeling bad, the things you do for that: warm shower, go to bed, lots of fluids, stuffy nose. Again, the nasal saline rinse is great. The cough, there's lots of over-the-counter cough remedies that you can try. Lots of fluid helps a cough, just because it helps you move what's in your chest. And this is just another little chart. This is from the Center for Disease Control that can help anyone differentiate between cold or flu. Because if it's a cold, you can't really take any preventative or treatment medicine. But if it's the flu, you can. So this looks at, if you come down and look at sneezing. Influenza, maybe, but with a cold, it's common. So we're on to the next speaker.
And if you all remember, I've introduced Kathy. I'll send you the bio on Ian.
She's taller. Can you hear me? Okay.
No.
Do you need me to talk even louder? I'll try. All right, and I cannot see.
Just make sure
Very
you're
well.
close to the mic.
Yeah, you
Yeah,
gotta
it's
almost
bigger.
touch it.
Really close to the mic.
I need bigger print. I can't see it. Even with my glasses.
Oh, that's the next slide. Okay, yeah.
Thank you.
Right.
Okay, I'm needing stronger glasses, I guess. Okay, so I'm going to talk about RSV. RSV, mostly we used to know about from kids before, but now we've been finding out that a lot of other people get RSV because we have tests for it. So RSV is a respiratory syncytial virus. Most people, if they get RSV, have a mild illness, but infants it can be pretty severe, and for older adults it can be pretty severe. It's seasonal, just like the flu. It's usually late fall through early winter, kind of the same time as the flu. It is highly contagious, just like most of the other viruses, like the flu and COVID. RSV can kill older adults, and the statistics say 6,000 to 10,000 older adults can die every year. RSV can cause hospitalization in older adults. Approximately 60,000 to 150,000 per year get hospitalized for RSV. The bad thing about RSV is there is no real treatment. It's just all supportive care. So if you get sick enough to have to go to the hospital, they're just, doing what they can to help you breathe better. If you're really bad, they can put you on a ventilator or give you a BiPAP or something to help you try to get over it. But there isn't like Xofluza or anything for RSV. There is now a rapid antigen RSV test. We typically don't use that test because there isn't anything really you can do. There's no treatment for it. We just kind of, if you're doing okay, you could have RSV, you could have something else. We do have tests for flu and COVID, so we will rule those out. And then other than that, you could have RSV or another virus. That's you're doing okay and you're not so sick that we think you have to go to the hospital, we just make sure that you have supportive care and get you through your body to, your immune system to work and get through the virus. So symptoms of RSV are very similar to everything else. Stuffy, runny nose, cough, congestion, headache, sore throat, mild fever, and fatigue. Incubation is also similar to everything else. This one takes a little bit longer, 2 to 8 days. It's usually more gradual onset, so it's not like the flu where you just feel like a truck hit you and you're in bed all of a sudden. It kind of sneaks up on you, more like the common cold. It is contagious, just like the other ones, a day before you have symptoms, and up to 8 days. And this one doesn't last quite as long as some of the other ones, mostly 3 to 7 days you'll feel bad, and then you kind of get over it and feel better. Of course, if you have certain conditions, it might be a little longer, but it's not quite as long as COVID or the flu. So for symptoms, this should look very familiar to you too. Same things, supportive care, over-the-counter medications can help you with your symptoms. Mostly, you just have to kind of wait it out and do what you can to feel better until you get over it. So prevention and treatment. There is no cure, like I said. There's no antiviral medication. You just treat the symptoms. And again, you try to prevent yourself from getting it in the first place. So always wash your hands. I mean, of course, you should do that all the time, but especially during flu, cold, RSV, whatever season. Stay away from people with symptoms. So if you're talking to somebody and they tell you they don't feel good, you know, maybe cancel your lunch with them or suggest that maybe they should stay home and rest. So RSV is especially dangerous for infants. So you want to, if you aren't feeling well, you're not sure what you have, but you're supposed to go see your brand new grandbaby, you should probably cancel that too and reschedule. And anybody who's immunocompromised, who's getting cancer treatment or something like that, they would be at higher risk for getting really sick from RSV. So, you know, try to stay away from anybody undergoing that too. The CDC did approve an RSV vaccine. So we do have something to help us prevent getting it. Or if we get it, it's similar to the flu and COVID, you may not get as sick. So they came out with it for adults over 60 last year in June. And now we have 3 different companies making the RSV vaccine. So if you're age 60 to 74, you can get it if you have certain chronic conditions. But anybody over 75, it is recommended. It can be given the same time as other vaccines. You can get your COVID booster and your RSV at the same time. You could get a flu shot, RSV at the same time. Most pharmacies now have it. I think the coverage is better than when it first came out. When it first came out, it took a little while for all the insurances to get on board, but I think most of them are covering it at least, you know, it could be different for your out-of-pocket costs, but at least it's not like it was at first, $350. Medicare Advantage, you have to check with your insurance. Every one of them covers different rate. Terrytown, when they come for the booster, I think they're bringing RSV with them too. So if you did not get an RSV shot, I would ask them to check your insurance and see how much it is and then decide if you want to get it or not. If you really want to get it, you might even call them ahead of time and find out, because they're going to be busy the day of the booster clinic, and I don't know that they'll have time to check your insurance. So the RSV vaccine is just 1 dose before the RSV season starts, so that's right now. It is not an annual vaccine at this time. So right now they're saying you can get one every other year. The immunity is supposed to last about 18 months. So it wears off in the middle of the time where there's no RSV season. So that's why they say you can wait and do it every other year. Now they may change that, but that's what the recommendation is now. There's several different companies are giving them. So if you get an RSV vaccine, you can still get RSV, but it reduces the risk for moderate or more disease, like you might end up in the hospital, by 78%, and for more severe disease, so that would be more the hospital. So moderate disease, meaning you're pretty sick, at home, laying in bed, or severe disease ending up in the hospital, by 86%. So it does help you, even if you get it, so you may just feel more like a cold. side effects of this vaccine are similar to all the other vaccines. Most common is like a reaction at the injection site. You might get a little sore and achy, but it's not any different than any of the other ones, so it's pretty safe. All right, Mindy's gonna do COVID-19.
Do you want it? You don't have to.
Okay.
I'm a mystery.
We've got Mindy the mystery. Well, Mindy Coakley works mostly over in healthcare, in the assisted
And
living.
assisted both.
Okay, in both, all right. And she's very difficult to get a hold of. You have to really be a patient over there. She's gonna be working in the clinic though, so you will see more of her. And the reason for her time in the clinic, upcoming time, will be Ian is having hip surgery. And she'll be out October 1st. Is that correct? You'll be home how long?
A month.
She'll be home a month. Okay, so we have Mindy. And Mindy has a lot of experience as well in primary care, home health, and hospice. She graduated from cum laude with a Bachelor of Science in Nursing from the University of Texas at Arlington. She earned a Master's of Science in Nursing from the University of Texas in Galveston. She's been working with older adults in long-term care, assisted living, and independent living since 2020. And she has a lot of special interest in holistic, palliative, and hospice care. So I believe you've been here about 4 years, 5 years?
Almost 5.
Almost 5 years. And in her spare time, she enjoys playing piano, singing, reading, and crocheting, which was a real surprise to me. So, welcome, Mindy, and thank you. I promise I'm gonna write everybody's name down that's here, so you get the real bio. I can tell you. I'll tell you the next time you come, all right?
Well, thank you for that. Yes, I started my tenure at Westminster in January 2020. So COVID has been my friend the entire time, pretty much, I've been at Westminster. What a crazy ride it has been, and it has not gone away. There's brief history here. Most of us are familiar with that. First appeared in China, it spread extremely rapidly, in part because it's a new virus. We think it hopped from an animal over to infect people, which means we have no immunity to it. So it spread really quickly, and at the beginning it was causing really severe disease. So upwards of 776 million confirmed cases since it was first found. And the true number of deaths is likely over 15 million, because those are things that get underreported. It did just go up. Hold on. Okay, no. Hello? Maybe ran out of battery. Okay, thank you. So, COVID has actually been pretty devastating worldwide, and it's probably worse than we actually know, because there are lots of places that don't track or have been unable to track. Right now what we're seeing is, as the virus has mutated, it's become more and more contagious, which seems crazy because at the beginning it's so contagious. All these mutations, they're more and more contagious, but not necessarily causing more severe disease so far, which is good for us. We're still seeing outbreaks several times a year, but we're seeing a lot fewer people with severe illness because many of us have had COVID, so we have some immunity, and we may still get it again, but it may not be as severe, and then a lot of people are vaccinated. Despite being vaccinated, I have had COVID 4 times myself. I went 3 years without COVID, and then I got it 3 times in the space of 12 months. That's because I bragged and said I must be immune to it, and the universe said, ha ha ha, so no. It's not yet seasonal. What we're hoping is this is going to be like the flu and like RSV, that it will be seasonal. Right now it is not. We keep seeing waves in the winter, in the spring, in the summer. So it does take, I read somewhere, between 10 and 20 years of a new disease to kind of really settle in for us to know what's going to be like going forward. So we're still early in this, although it feels like forever. Right now, the way they're monitoring what our risk is of getting COVID is actually by the viral load they find in wastewater, because no one's tracking it and reporting it anymore. And then also they look at the rate of hospital admissions. That data can be a little inconsistent because we don't have a real good way of making sure we find all of those people, but they are reporting those things. Weekly cases right now are dropping in the United States, but we had a big surge January to March and then again June to July. And the predominant, if you're interested, that's the predominant variant, but it's just great-great-great-great-great-great-great-great-grandbaby of Omicron, which was the first or second mutation. So signs and symptoms of COVID, this should all look really familiar. It's pretty similar to flu. It can be very mild and almost seem like a cold or allergies. It can be more severe. More severe, what we will tend to see is shortness of breath, trouble breathing, lower oxygen levels. Those are times to definitely seek medical care. You can have GI symptoms with this, nausea, appetite loss, and vomiting. It's a little more common to have a loss of taste or your sense of smell, which that happened to me one of the times. It was really weird. I put just straight vinegar on my hand and I couldn't taste anything at all. Lots of viruses can do that. It just seems to happen more consistently with COVID. And then there have been people who've gotten strange rashes and these nodules on their toes. They were calling them COVID toes. I haven't heard a lot about that recently, so I'm not really sure what's happened to it, but I also didn't really investigate because, All right. So the incubation period is not very helpful. It can be 2 to 14 days. That's a really big spread. Usually it's about 4 days. But if you were exposed to COVID and you say, it's been a week, so I'm fine, maybe, maybe not. The onset is usually gradual. The flu hits you like a truck, like you're fine 1 minute and the next you don't want to get out of bed. COVID is a little more gradual, kind of some little symptoms at first, and then over the course of a few days they start to get worse. The contagion period is long, 1 to 2 days before your symptoms start, to 10 to 14 days, sometimes even 20 days or longer. People who are immunocompromised can sometimes be contagious for much longer. So you can see too, this all facilitated the spread because you could be sick and you don't know it for 14 days till you get symptoms. The duration is usually 7 to 10, 14 days. However, long COVID, which is a cluster of ongoing symptoms like fatigue, sometimes cough, brain fog, that can last months, and there are now even people who've had it for a year plus. So they're doing a lot of research still into why it affects us in that way. But for most people, once you're over it, you're over it. So how it spreads, usually it's close contact. We call it droplets, so you cough and there's small particles in what you cough into the air. If that comes in contact to someone who's not infected, they breathe it in. However, it can become aerosolized, which means it's just kind of hanging in the air, and you can walk by 10 minutes after the person left and walk through it and get it that way. It's not spread, it seems, as commonly that way, but there's also a lot of controversy about it that I'm not going to get involved in, but there you go. Direct contact with an infected person or touching surfaces that have the virus on it. That's why, if you remember in the heyday, we were wiping everything down every 5 minutes and washing our hands, and more contagious than influenza. We kind of talked about that already. So right now, for most of us, COVID is not necessarily too severe unless you're unvaccinated. For vaccinated folks, if you're a little bit younger, you're less likely to have severe disease. But people who are at highest risk for severe disease are people 65 and older, people who are immune compromised. We have found with COVID there are certain chronic illnesses that really make you more susceptible to severe disease, meaning ending up in the hospital. And that can be chronic kidney or heart disease, chronic lung problems, liver disease, diabetes, and then cancer, HIV, and actually having dementia seems to cause people to have more severe disease. I don't know why, but I also have not researched that. So maybe I'll research it for next year, and I'll let you know if you come back. People who are obese or pregnant, and of course people who are unvaccinated. So COVID can have some pretty severe complications. This is part of the reason why it's made such a splash. Pneumonia leading to respiratory failure is not uncommon if you have severe disease. You can develop permanent lung damage, which is scarring in your lungs after having COVID. You can become septic, which is basically where the infection is bloodborne, and that can be really severe and that can be deadly. It leads to organ failure. You can actually suffer cardiac injuries, you can go into heart failure, develop abnormal heart rhythms, blood clots. Yeah, exactly. What can't it do? Secondary bacterial infections, so your immune system is overwhelmed and actually working overtime, so it's overwhelmed. It provokes this really heightened immune response. And so people can get secondary infections. The most worrisome of these is really the fungal infections, because typically most people don't get those. They can be extremely serious and difficult to treat. And then there's long COVID, which we talked about a few minutes ago. It can appear like your symptoms never quite resolve, or it can start several weeks after you were sick. And how sick you are does not predispose you to long COVID. You can have severe illness and have been in the hospital and not get long COVID. You can have been tested positive because you had a runny nose, you never had any other symptoms, and you can still develop long COVID. Morbidity, mortality. The reason I have this up here, we don't necessarily need to, I'm not going to talk about every single number, is just to compare. People are still in the place where like COVID is just like the flu. Well, it's similar, but it's not, as you can see, like the number of hospitalizations, the number of deaths. Again, this is a new friend, so we don't have a lot of immunity. We don't know how, we're still learning about how to best combat it. But one of the important things to note is that 74% of all COVID deaths occur in adults 65 and older. So this is why we push for those boosters. We're all tired of getting boosters, tired of keeping track of them. I don't have any more room on my vaccine card because I've gotten so many boosters, but this is what, why we're encouraging you to get those. We don't have a lot of good track data, so I can't really tell you much as far as like what's happening right now on a state-by-state basis with COVID. So you don't even have to necessarily read all of that if you don't want to, but the approved treatments, as you can see, there are only 4. There's Paxlovid, which is the one that's used the most. You have to start it within 5 days of symptom onset. It can be very expensive, but it is covered by most insurances. It has a lot of medication reactions. You can't take it if you have bad kidney disease. And some other issues, or if you're on some certain medications. However, it reduces the risk of hospitalization or death by 89%. That's really, really high efficacy for a medication. It's very impressive. You can, right now we only recommend it for people who are very high risk. Older adults who are very high risk is, some doctors give it to anybody, but that's still the recommendation. You can get rebound COVID, which is where your symptoms get better, you take the medicine, your symptoms get better, you stop the medicine, and 2 days later, all your symptoms come back and you start to test positive again. That actually can happen even if you don't take Paxlovid. That's just unfortunately one of the difficult things of dealing with this particular virus. So there was the other COVID medicine, molnupiravir, that was developed, and they said, oh, it works great in the trials. And when we got into the real world, it doesn't really help very much. It has a very modest benefit for people who are unvaccinated. It doesn't seem to have any benefit for people who are vaccinated. There's only up to a 3% reduction in hospitalization or death. So why would we prescribe that instead of Paxlovid? The only time might be someone who is high risk and cannot take it because of the drug interactions, can't take Paxlovid. Sometimes some people are still prescribing it, but a lot of organizations are not recommending it, medical organizations. There is an IV antiviral medication, remdesivir, that is for people who are pretty severely ill. You have to get it 3 days in a row, an infusion, and because of there can be an infusion reactions, this is typically only done in the healthcare setting. We have given it in the healthcare center, but we don't give it at the clinic or in people's homes because we don't know how you're going to react to the first dose, so you need to be someplace safe. And then convalescent plasma, this was something we were really hoping was going to help. They take plasma from people who had the virus so that they have some antibodies. We can push that over to new people, but that hasn't really shown to be of huge benefit, but sometimes trying something is better than trying nothing. So it is still used, but infrequently. And again, that's in a hospital or a healthcare setting and not outpatient. Symptom management, this should look so familiar now. It's actually the exact same slide. All of these things are what you're going to want to do. If you're not sure what you should take, you can always ask your primary care or your friendly neighborhood nurse practitioner, and we'll help you figure out what you should take. It can be confusing. So vaccination, again, the best treatment is prevention. The original vaccines, the Pfizer and the Moderna vaccines, had an overall efficacy of 90 to 95%, which is unprecedented for a vaccine. It's actually pretty incredible how quickly they developed it and how efficacious it was. It's estimated it prevented more than 1.2 million hospitalizations just in the US in 2021. So there was a booster that came out last year, and it was only about 52% effective at preventing infection and 67% preventing hospitalization. The protection peaked after 4 weeks, and it really waned after 10 weeks. So that was because it wasn't really a very good match by the time they developed it. This virus mutates so quickly that it wasn't really effective against the circulating virus. They're hoping they're ahead of that with this booster. That's the hope. So we do have an updated vaccine available. I listed here vaccine side effects. Y'all have probably had a lot of vaccines, so you're aware of this. The only thing I want to talk about, because people talk about it who don't really know what they're talking about sometimes, is the problem of the risk for injury to your heart muscle. This typically only occurs in adolescents and young adults, most often males. And so you can have this inflammation of the heart muscle or the lining of the heart. That's myocarditis, pericarditis. It is actually generally mild. That sounds really bad, and it can be, but in this case, usually it's mild, and you don't get any treatment, and people aren't even in the hospital. Don't even have to stay in the hospital for it because you're stable. However, the risk of either of those conditions is much higher, 2 to 5.5 times higher with COVID infection versus getting the vaccine. So you're still better off getting the vaccine and still actually less risk of that happening. So we still have 3 available vaccines. This is a schedule for people who are not previously vaccinated. Probably most of you here are already vaccinated. They've changed some of the recommendations in the last year. How long are we gonna need these boosters? Our hope is we'll get to once a year like the flu. They're actually testing a combination flu COVID vaccine. So you'd only get one shot and you'd get protection from both of those. That's in testing right now. What I read, the research I read said the early tests are looking pretty good, but that can happen and the long-term tests don't look so well. So that may be coming, fewer actual shots in your future. Let's see. So I thought of a few questions for you. Maybe common, and then we'll let you ask questions if you have them. Can you get a COVID vaccine and flu vaccine on the same day? Yes. Can you get a COVID vaccine and RSV vaccine on the same day? Yes, you absolutely can. Some people like to space them apart, but there's no contraindication to getting those together. What if you come to the flu clinic here at Westminster? Can I get a record of my vaccine? You can, but we don't necessarily give it to you right away, if I'm correct in that, Kathy. Like, we send it to you afterwards. We have to do our documentation, then we'll send it to you. Can you send a record of my flu vaccine to my primary care? Absolutely, if you give us their name. So if you bring that when you get your shot or call us with that at some time in the future, we can send it to your primary care. I think on the form there's actually a space, the consent form, where you can write that in on the day of. Now I'm summing up the entire thing: cold, flu, allergy, RSV, COVID. How do I know what kind of infection I have? So how do I know if I can treat it? Come see one of us. Or your primary care for testing. Sometimes we can't do a test that's absolutely going to confirm, but we can often rule things out. If we can rule out COVID and flu, then any of these other conditions, a cold or RSV, don't have specific treatment. So we don't really need to pinpoint exactly what it is. We're just going to treat you and take care of you until you get better. But your doctor or your primary care provider, or you can come see us and we can help you get tested and figure out what's going on. So I'm going to put this up. These are our upcoming vaccine clinics. Tomorrow is the COVID vaccine clinic right here. No, the 20th, Friday. I have been a day ahead all week this week. My apologies. So the 20th from 10 a.m. to 1 p.m. You do have to be pre-registered. They're not taking walk-ins. Part of the reason for that is needing to do insurance checks, but the other part is because you have to open files, and if there are multi-dose files, and we don't want to waste it. So they need to know how much to bring. If you have signed up, bring your COVID vaccination card if you have room on it, or we can start a new one for you, and bring your insurance card unless you've already given them all of that information. Call Robin if you need help registering. So if you're like, shoot, I forgot to do that, it's on the 20th. I think we can still request an appointment. Do you know, Kathy, for sure?
I haven't heard that we can.
Okay, so it's Terrytown Pharmacy is going to be coming here and giving those shots. Our Westminster Wellness Flu Clinic, flu clinics, we have multiples, September 26th, October 2nd, and October 3rd. You can sign up at the Wellness Clinic, like Ann mentioned earlier. There's a sign-up book outside of the clinic in the waiting room. We try to kind of do groups of people together so we don't end up with a huge long line, everybody waiting. Signing up helps us keep things moving. However, if you don't sign up or you forget what time and you come at the wrong time, we'll work you in. You just might have to wait a little while. If you've had an insurance change this year and you have not yet told us, you really need to bring your card to the flu clinic. If you've already updated it with the clinic, then that's great. Don't worry about it. If you are not sure, you can call, and our lovely Alyssa at the front desk can look up and verify insurance, that we have the proper insurance for you. So that is all for me. And questions?
We have to share a mic.
You're gonna have questions?
Yeah, let's see what we can get the batteries on this. No, it's still.
That's all right, we'll
Okay,
just shout.
want to ask you a question?
Yes. I was just, I've been in isolation with COVID, and it stated on a piece of paper that I got from the wellness clinic to stay in isolation to the 16th. But I didn't feel well, and I stayed in isolation to the 18th. Question, why is there no recheck to see if I have recovered from COVID? Is there a way to recheck? Second question, in case you keep my mic, is having had COVID recently, can I go ahead and take the COVID shot Thursday?
So the answer to the first one is, can we recheck? We can recheck you. That's not really what those tests are designed for. So even if you are no longer infectious, sometimes you can still have viral particles that will get picked up by the test and they will test positive. So it's just not a very good way. We tried that early on doing cure tests and we stopped it because they're not that accurate, to be honest, in that situation. So that's why. And then can you get the COVID vaccine? Technically, according to the CDC, you can, even if you've recently had COVID. However, we usually say if you wait 60 to 90 days, you're gonna have some immunity from the infection you have right now for probably 60 to 90 days. So it is okay to wait a little while and then get your booster because you already have a measure of protection right now. And so that way, the COVID vaccines also do wane over time, over about 3 months or so. Sometimes they peak in 10 or 14, they peak in 4 weeks, and then it slowly wanes, which is why we have to keep getting them. So you might want to use your immunity now and save the vaccine for later in the season.
And referred to checking about taking Benadryl. Why is that? I've never heard that.
So what I was saying was if you have a combination medicine, then make sure that you know what the different drugs are in the product. And then if you have questions about whether this might interact with some of your medicines or some of your conditions, to check with the MPs.
Any other questions?
I signed up to get the COVID vaccination, but I'd also like to get the RSV. Now, do I need to let them know so they bring the right amount?
I would call them, like today or tomorrow, and ask them if you need to let them know in advance. I think they're just bringing some, like 50 of them, and then they're asking people when they get there. But I know last year, some people didn't have coverage on their insurance yet, or it was more than they wanted to pay, and then they got a bill later. So I'm telling people, if you want to get the RSV, call Terrytown, ask them if they need to know ahead of time, and if they can check your coverage, and then you can decide. Because it's kind of chaotic. If you've been to a clinic, it's really busy, and you know, I think it's easier if they do it in advance. Did everybody hear that? Okay, so she asked about the RSV if she wants to get it with the COVID booster on Friday. And I suggested that she call Terrytown, ask them, A, do they need to know ahead of time, and B, ask what her coverage is, because it does vary by your insurance. If you just want to get it no matter what and you don't care about that part, you still need to know if they need to know in advance. Last year, people did not let them know in advance, but I know, you know, with the costs and everything, it was a little bit muddled. So that's what I would do.
Is that a question coming up?
Betty, I think Benadryl is contraindicated if you have glaucoma. That's my recollection, because I've got glaucoma and I think I'm not supposed to take Benadryl, but I'm like not 100% sure. And then a friend who's recently told me in Austin there's COVID rehabilitation clinic. Do y'all know anything about that?
I know that there is a long COVID clinic at UT.
Maybe that's
So,
what she was referring to.
I don't know, I haven't heard anything particularly about rehabilitation clinic. I know that there are several people that I'm aware of that are going to the long COVID clinic at UT.
Okay, maybe that's what she meant. Okay, thanks.
Anybody else have a question?
Is this
Alright.
RSV real common here? Oh, common here.
I'm wondering how common RSV is around here. I haven't heard hardly a thing.
I don't know around here. I just know they have a test for it now. And so if you go to the hospital and you have respiratory symptoms and you have influenza negative and you're COVID negative, they're gonna check you for RSV. So it feels like more people have RSV, but I don't necessarily think that's true. I just think they can test for it now. So, and they developed the vaccine. So, I think it's all kind of related. We're hearing more about it, so it feels like it's more common, but it may not be. And I don't know exact numbers in Austin.
So if I make a trip to California, for example, it may or may not be more prevalent.
I think it's kind of like the flu. It's kind of all over. It's more dangerous for children and certain older adults. And so I think they do vaccines for
It's not vaccines, it's immunoglobulin.
Yeah, they do different things for kids, but
Only certain kids.
if you're traveling, it's just like any other time when you're on the airplane. There's a lot of people in a small space. You can catch anything. I would say just get the RSV vaccine.
And wear a mask.
And wear a mask, but you just can't get away from it. There's nowhere for the air to go except around you. So if you're not wearing a mask, if you're vaccinated for everything, it does protect you. So if you do catch something, you don't get that sick.
So with all those symptoms that you've itemized on the boards, are you telling us we should stay in our apartments and call you?
If you get sick, definitely call the clinic. Sometimes we have you come down in a mask. If we're not able to do a lot of home visits, we'll have you come down in a mask and we'll test you and find out what's going on. If you feel terrible, certainly stay home. We will find somebody to come up and see you. We don't want you coming down to the clinic and you look terrible and, you're sitting in the waiting room and you're coughing and your eyes are, we'd rather you stay home if you're feeling that badly. But if you just have mild symptoms and you're not sure, you can still come down to the clinic. But always call and talk to Alyssa. She'll figure it out and decide what the best thing is and we'll get you seen.
Any other questions? Well, thank you. Thank you to the three of you and appreciate your time and you identities.
She asked me one question. If we are going to get a portal, we actually have a new computer system. We've had 3 weeks now, and it does have a portal. So if you come to the clinic and you want to be invited to the portal, we will invite you to the portal. I know we're having a little bit of issues getting it figured out, so you have to be patient about that. But there is a portal, and you can get your lab sent to you, and you can get copies of your notes and that kind of thing. So, yes, ma'am.
I'm sorry, I just thought of something. So if I wanted to use, is it a good idea, if I may have been infected, to at least first use the home kit? And where do you get them?
So it's not as easy to get them. They don't just give them to you anymore. You have to go buy them.
Want to repeat that question?
Yeah, the question was, what do you do if you think you might have symptoms? How do you get a home test kit? They're not just sent out to you, 8 kits like they used to be. You can still buy them at the pharmacy. We have the rapid kits. So if you're here, we will do it for you. Now, the rapid kit works the best if you have symptoms. If you're just exposed and you just want to see, it doesn't work very well if you don't have symptoms. So if you only have 1 or 2 test kits, don't check yourself every time you were around somebody coughing. I would wait until you actually have symptoms or call us down at the clinic. We have the PCR that we have to send out. That's a more sensitive test. But we also have the rapid test in the clinic. And we'll come to your apartment and bring it. We'll do it in the clinic. That's a good starting point when you have symptoms to try to figure out what's going on. And we have the influenza kits too when it's flu season.
Thank you, everyone. Thank you.